Welcome to Falcon Pathology Review for USMLE Step 1. We're now moving on to the second part of our lecture on the female reproductive system. What we will be dealing with in this section are lower and upper genital tract infections, disorders of the uterus, endometriosis, and disorders that affect the fallopian tubes. Chlamydia trachomatis is a form of bacterial infection, serotypes D and K, D through K being the most common to produce sexually transmitted disease. It can affect various sites within the female reproductive system. It can produce a cervicitis and is a common cause of pelvic inflammatory disease. Neisseria gonorrhea begins in the vestibular and periurethral glands. The lower tract symptoms are due to an acute separative reaction. It ascends up the mucosal surface of the female reproductive tract and, similar to chlamydia, can cause pelvic inflammatory disease and, not surprisingly, is a sexually transmitted disease. Now, Neisseria can also cause extragenital infections, pharyngitis from oral sexual contact, proctitis from anal sexual contact, and a purulent arthritis, often monoarticular, from untreated disease, and ophthalmia neonatorium, neonatal conjunctival infections, which are the reason why all neonates receive appropriate antibiotic treatment to their eyes after birth. Now, PID, which can result from infection with gonorrhea, chlamydia, or potentially even other agents, is characterized by pelvic pain, adnexal tenderness, fever, and a vaginal discharge. It can result again from infections from various organisms, the major players being chlamydia, Neisseria, or it can be polymicrobial with effects from enteric bacteria. This usually occurs after abortion or a delivery, the bacteria spreading from the uterus upward via the lymphatics or surrounding veins. Complications from pelvic inflammatory disease include peritonitis, intestinal obstruction secondary to adhesions, bacteremia, and infertility. Now for disorders of the uterus. As you see in this picture here, when we deal with the uterus, we're dealing with essentially the body of the uterus. We've dealt with the cervix separately, and so now we're going to concern ourselves with the fundus, and then the disorders of the endometrium and myometrium of the body of the uterus itself. Remember, however, when one refers to the uterus, you are referring not just to the body of the uterus, but also to the cervix, even though many people, including many obstetricians, tend to consider them to be the same entity. Dysfunctional uterine bleeding refers to any form of abnormal uterine bleeding. The cause will generally depend upon what age group you're dealing with. Common causes are considered to be things such as anovulatory cycles, endometrial polyps, leiomyomas, or, more disquieting, endometrial hyperplasia, which can be a premalignant condition leading to endometrial carcinoma. Anovulatory cycles are seen where there's excessive estrogen stimulation without the development of progesterone phase, i.e. there is failure of ovulation. This is usually due to some sort of hormonal imbalance, usually during menarche or perimenopausal period. Anovulatory cycles can also result from various endocrine disorders, including thyroid disease, diseases of the adrenal or pituitary tumors, anything essentially that can upset the endocrine axis. Various ovarian lesions can also lead to an anovulatory cycle, including the granulous theca cell tumors or polycystic ovaries, anything that upsets the delicate estrogen-progesterone balance. And finally, generalized metabolic disturbances can come about if the patient is obese and there is excess estrogen synthesis out in the fat, malnutrition, or patients who are burdened with a chronic systemic disease of some type. In terms of structural abnormalities that can lead to dysfunctional uterine bleeding, endometrial polyps are a common cause. This is simply a benign finger-like projection of endometrium that can cause abnormal bleeding, usually seen in women under the age of 40. Leiomyomas we have mentioned earlier in our section on tumors of the soft tissues. They are a smooth muscle tumor common in women of reproductive age. For those of you on the wards, you may have heard these also referred to as fibroids. They are the most common tumor in women, and they are thought to be estrogen responsive as they increase during pregnancy but decrease after menopause. Patients present with structural changes to the uterus which results in abnormal bleeding, compression of the bladder, or infertility. This is an example of a uterus expanded by leiomyomas. Note they are the sharply circumscribed white tumors, which gives you hints to their benign nature. Then they bulge in and compress the endometrial cavity. Leiomyosarcomas, these are simply the malignant version of the leiomyoma. They are tumors of smooth muscle that invade into the uterine wall. Note that they usually arise de novo. That is, one rarely progresses from a leiomyoma to a leiomyosarcoma. This generally have a slightly later peak incidence than what one sees with leiomyomas, occurring in the age group somewhere between the ages of 40 to 60. Finally, another cause of dysfunctional uterine bleeding is endometrial hyperplasia. Endometrial hyperplasia is thought to be related to abnormally high, prolonged levels of estrogenic stimulation of the endometrial lining with low progesterone activity. It's detected most often by the presence of abnormal bleeding, especially that occurs postmenopausally. Endometrial hyperplasia is considered a risk factor for endometrial carcinoma. And indeed, endometrial hyperplasia can proceed through a series of stages, very similar to what occurs with cervical intraepithelial neoplasia. And there's a grading system now being instituted to determine what is called endometrial intraepithelial neoplasia, which proceeds through a series of grades, EIN 1 through 3, with 3 being essentially a form of endometrial adenocarcinoma in situ. Endometrial carcinoma is unfortunately the most common invasive cancer of the female genital tract. You see it most frequently in most postmenopausal women who present with abnormal uterine bleeding. It is uncommon in women under the age of 40. Risk factors are essentially anything that leads the patient to having increased estrogen exposure. So think about this in patients who are obese and also patients who are infertile. You see an example of the glandular formation of endometrial carcinoma here in the slide that accompanies here. Note the sharply circumscribed lumens, but then the different shapes the glands take on as they invade down into the myometrium. Now there's a subset of patterns to endometrial carcinoma. Older patients will tend to present with high-grade endometrial carcinoma, what is termed a papillary serous form, that often occurs without the intervening background of hyperplasia. That is, they don't proceed from having a series of endometrial biopsies that show endometrial hyperplasia or atypical endometrial hyperplasia or endometrial intraepithelial neoplasia, and instead present with abnormal uterine bleeding, and then when biopsied, show the sort of polypoid form that we see in the slide here, with atypical endometrial cells covering these fibrovascular stroma and creating these papillary projections out into the endometrial lumen. These tumors are noted for having microsatellite instability and p53 mutations when studied genetically. Now this brings us to endometriosis. The endometriosis simply refers to the presence of endometrial glands in abnormal locations outside the uterus. Most of these sites are usually going to be pelvic in location. The ovaries is the most common site, but you can also see little islands of endometrium within the uterine ligaments, the rectovaginal septum, and also within the pelvic peritoneum. Adenomyosis is the presence of endometrial glands within the uterine wall, and is generally thought not to be of any clinical consequence, other than that the pathologist who must determine is this adenomyosis versus an invasive endometrial carcinoma. Endometriosis is noted for causing pain, and the islands outside the uterus will cycle as the endometrial lining within the uterus cycles as well. The way in which endometriosis is thought to occur, there are various theories, including the regurgitation theory, which states that there may be retrograde menstruation through the fallopian tubes into the peritoneal cavity, leading to seeding of the uterine ligaments, ovaries, and other places with fragments of endometrium. The metaplastic theory, which states that the endometrium arises from a coelomic epithelium. And then what's termed the vascular or lymphatic dissemination theory. And this is thought to be the reason why you can have endometrial lesions extending all the ways into the lung. Endometriosis suffers severe dysmenorrhea and dyspareunia, along with pelvic pain due to intrapelvic bleeding, and creates periuterine adhesions. Pain on defecation results, it's thought, from endometriosis affecting the rectal wall. Dysuria affects involvement of the cirrhosis of the bladder, and menstrual irregularities are often the common presenting complaint. The chocolate cyst is the classic gross presentation of an endometrial cyst. You see it here in this example, most likely of a fallopian tube and the surrounding uterine tissue, where a large endometrial cyst has been opened up, revealing its contents to be a mass of necrotic dark brown material due to the extravasated blood from the cycling of the endometrial tissue. Finally, in this section, we come to the topic of fallopian tubes. Inflammation affecting fallopian tubes usually comes about with inflammation of the ovaries and adjacent tissues. That is, it's due to pelvic inflammatory disease. With cases of suppurative salpingitis, your largest actor in here is going to be gonococcus, which will account for more than 60% of all cases. Tuberculous salpingitis is very uncommon. Any of these disorders, however, when they infect the fallopian tubes, can lead to various things such as pyosalpinx, hydrosalpinx, or tubo-ovarian abscesses. One can imagine that with those abscesses and the development of inflammation, one is at the risk for development of adhesions, the walls of the fallopian tube potentially adhering together, which predisposes to the development of ectopic pregnancies and infertility. Tumors and cysts that one may see around the fallopian tube include hydatid and morgani. These are simple, basic, translucent-filled cysts filled with fluid. These can be found as quite normal findings even within women without any other complaints within their reproductive system. Adenocarcinoma, although the primary malignant tumor of the fallopian tubes, is generally from a metastases of some type, primary adenocarcinoma being rare, and is diagnosed as primary adenocarcinoma of the fallopian tube only after excluding other primary sources. That concludes this section of the female reproductive tract for the Falcon Pathology Review for USMLE study.